Welcome to the deep dive. Today, we're plunging into a topic that might seem a bit niche, maybe, but it's actually full of surprises. And, it can tell us a lot about what might be going on beneath the surface. We're talking about atypical wounds.
That's right. And for this deep dive, we've really focused on the chapter Atypical Wounds, from Wound Care Essentials, Practice Principles. The main book is by Sharon Baranowski and Elizabeth Aiello, but this specific chapter had key input from Robert S. Kersner and Brian A. Kahn.
Okay, got it. So what's our mission today for the listener?
Well, our goal is really to unravel what makes a wound atypical,
Mhm.
not your standard cut or scrape, and why spotting these unusual cases is so important. Plus, we'll explore some of the, frankly, fascinating, less common reasons they actually develop.
Right, so giving people a clear picture without getting totally bogged down in, heavy medical jargon.
Exactly. That's the plan.
Okay, so when we think about wounds that just won't heal, most of us probably jump to, the usual suspects. Things like problems with blood flow, maybe varicose veins, or complications from diabetes, or even just pressure sores from being in one position too long.
Yeah, absolutely. The vast majority, really, of chronic wounds fit neatly into those well-understood categories. Venous issues, diabetes, pressure, poor circulation that covers most of them.
But atypical wounds are the odd ones out then.
They are. They pop up because of less common underlying issues, things that sort of fall outside that main group of reasons why wounds typically become chronic or difficult to heal.
So give us some examples. What kind of less common underlying issues are we looking at here?
Well, our sources, they highlight several general categories. Think of things like inflammatory conditions causing wounds, various kinds of infections, some quite rare, maybe things you never even heard of.
Okay.
Then there are traumatic causes that happen in unusual ways, problems with the body's metabolism, even something serious like a malignancy, like a tumor. And also genetic conditions and, perhaps surprisingly, injuries that people actually inflict on themselves, which are called factitious injuries.
Wow, that is a really wide spectrum. It definitely highlights why recognizing them is so crucial, doesn't it? I mean, you can't just treat a wound caused by some rare infection the same way you'd treat, say, a diabetic foot ulcer, right? The root cause is completely different.
Precisely. That's the core message. The way you manage the wound, the actual treatment you need, it all depends entirely on figuring out what's really causing it in the first place. The book really hammers this point home.
Okay. So how does a doctor or any clinician really even begin to suspect that a wound might be atypical? What are the clues that make them stop and think, this isn't quite what I usually see?
Yeah, that's a great question. There are really three main things that should raise a red flag. First one is an unusual location.
Location, how so?
Well, for example, pressure injuries or bed sores, they usually happen over bony spots, right? Like the hips, the tailbone, the heels. So if you suddenly see a significant ulcer on someone's thigh, where pressure isn't typically a major factor, that should make you think twice.
Ah, okay.
Or, similarly, venous ulcers, they tend to show up on the lower legs, kind of above the ankle. So if you see something that looks like one, but it's, I don't know, way up on the thigh or somewhere else, entirely unexpected, the location itself is a big clue that something else might be going on.
That makes perfect sense. It's like finding, a seashell in the desert. It just feels out of place. What's the second indicator then?
The second is an uncharacteristic appearance. So even if the wound is in a common spot, the way it looks might be off.
How do you mean off?
Well, the text gives an example of a wound, say, on the inside of the lower leg. That's a pretty common place for a venous ulcer. But maybe this one goes really deep, like all the way down to the tendon. Yeah, that kind of depth isn't typical for a standard venous ulcer. It suggests something else might be contributing to the problem, making it more aggressive or destructive.
Okay, so location and appearance, the where and the what of the wound, got it. What's the third thing that should make clinicians think atypical?
The third big one is when a wound just doesn't respond to conventional therapy. The usual treatments aren't working.
Ah,
So if a wound hasn't shown any real signs of getting better after, say, 3 to 6 months of proper, appropriate care, even if it initially looked like a common type of wound, it's definitely time to step back and consider if there might be a less common reason why it's just stuck, why it's not healing.
right.
So the core insight here really is if a wound isn't behaving as expected, either where it is, what it looks like, or how it's healing or not healing, that's your signal to think beyond the usual suspects.
3 to 6 months, yeah. That's a long time for something not to be improving. If it's not getting better by then, you definitely need to dig deeper. Now, you mentioned the source material really stresses how important biopsies are for these kinds of wounds. Why is taking that small tissue sample so critical?
Yeah, the text makes it very clear. Biopsies are often an absolute must for atypical wounds. The big reason is, well, many of these unusual conditions can look surprisingly similar to each other, just visually.
Ah,
So trying to diagnose it based purely on what you see, that's really difficult and honestly pretty risky. You could easily go down the wrong treatment path if you misdiagnose it just by looking.
so we can't just glance at it and say, aha, that's definitely that rare thing I read about.
Exactly. Not usually, no. A biopsy allows for a much more detailed look. That tissue sample can be examined under a microscope that's called histologic evaluation, and they often use special dyes or stains to highlight specific types of cells or proteins that might give clues. They can also try to grow any bacteria or fungi that might be lurking in there. That's tissue culture, which is crucial for infectious causes.
Right.
And for some conditions where the body's own immune system might be involved, they can do special tests called immunofluorescence. These look for specific antibodies or immune proteins deposited right there in the tissue.
So the biopsy gives us this much more microscopic, much more accurate picture of what's actually happening. Okay, let's dive into some of these specific causes then. The chapter mentions inflammatory causes first and says they're interesting and maybe even more common than we realize. Vasculitis is one of the first examples. What exactly is that?
Right, vasculitis. You can think of it as a situation where the body's immune system essentially makes a mistake and attacks its own blood vessels. This causes them to become inflamed and damaged.
Oh, okay.
And that inflammation can eventually cut off the blood supply to the tissues those vessels feed, like the skin, in this context leading to damage, necrosis, and potentially ulcers.
And what triggers this attack?
Well, the source notes that in about half the cases, they actually don't know the exact trigger. It's called idiopathic. But it can also be brought on by underlying things like infections, certain cancers, some medications, and even autoimmune diseases, where the body's already kind of attacking its own tissues, like lupus or rheumatoid arthritis.
And does it always look the same on the skin?
No, it can vary quite a bit depending on which blood vessels are affected, like the size of the vessels. If it's the really tiny ones near the surface, you might see something called reticulated erythema. It looks kind of like a lacy or net-like pattern of redness on the skin.
Okay, like a net.
Yeah, exactly. If it involves slightly larger vessels a bit deeper, it can show up as something called palpable purpura. Those are like raised purplish spots you can actually feel. Or it can cause areas of skin death, which is necrosis, and open sores or ulcers. The text actually refers to a picture, figure 22.1, showing this sort of net-like redness and necrotic ulcers on someone's thighs. It really gives you a visual.
It sounds pretty serious. And the source also points out that the skin problems might just be one piece of a bigger puzzle, right?
That's a really crucial point. Vasculitis isn't always just skin deep. It can affect blood vessels in other organs too, kidneys, lungs, nerves, even the digestive system.
Wow.
So if a skin wound looks suspicious for vasculitis, doctors will often do a more thorough checkup to see if other parts of the body are involved.
And how does it actually cause the damage? The text mentions immune complexes.
Yeah, often what happens is these little packages of immune proteins and antibodies called circulating immune complexes get formed in the blood. They then get stuck in the blood vessel walls, and that triggers the inflammation and damage.
And diagnosing it, you mentioned biopsies earlier. Is that the key?
Yes, getting a biopsy of the affected skin and getting it early on is really the best way to confirm vasculitis. That allows them to see the inflammation in the vessel walls and sometimes even detect those immune proteins using immunofluorescence.
Why, right?
Well, if the biopsy is done later, say after the inflammation's been going on for a while, those immune components might have broken down, making it harder to get a clear immunofluorescence result. And if they suspect an infection might have triggered it, they might also do tissue cultures from the biopsy.
Okay, and treatment.
Treatment really focuses on tackling the underlying cause, if one can be found. So, if it was triggered by an infection, antibiotics are key. For the vasculitis itself, it depends on how severe it is. Mild cases just affecting the skin might only need supportive care, like elevating the legs, using special dressings, maybe some medications like colchicine or dapsone.
And for more serious cases.
Right, for more serious cases with widespread skin involvement, or if other organs are affected, they often need stronger treatments. That usually means things like steroid pills or other medications that suppress the immune system to calm down that attack on the blood vessels.
Okay. Next up in the inflammatory category is pyoderma gangrenosum, or PG. Now, that name itself sounds pretty intense, like an infection causing gangrene. But the text clarifies it's actually not infectious or truly gangrenous. So, what's the deal with PG?
You're absolutely right. The name is incredibly misleading. It sounds awful, but PG is actually an inflammatory condition that causes these really painful skin ulcers. It's not caused by bacteria multiplying or tissue death from lack of blood flow in the typical gangrene sense.
So, what does cause it?
Well, we don't know the exact cause for sure, but the current thinking involves a mix of issues. There seems to be a problem with how certain white blood cells, called neutrophils, function. There might be genetic factors involved too. And there's a general state of inflammation in the body specifically, a dysregulation of the innate immune system, kind of like it overreacts to injury.
And what does it typically look like? How would you recognize it?
PG is known for causing these chronic ulcers, and they often have very distinctive features. The edges are usually described as violaceous, meaning a purplish color, and they're undermined.
Undermined.
Yeah, it means the skin sort of hangs over the edge of the open sore like a little cliff edge. It's not just a straight drop-off. The text actually has some pictures, figure 22.2a and b, that really show this characteristic appearance.
Okay.
It mostly affects adults, and it tends to have this course of recurring, quite destructive ulcers. They often start out as small, pus-filled bumps or pustules, and eventually when they heal, they leave behind these sort of pitted, sieve-like scars. The book calls them cribriform scars.
Cribriform, like a sieve or a strainer.
Exactly, like a strainer pattern. The source also mentions that PG can show up in different ways. They call them clinical variants. So it might be the classic ulcer, or it can be more pustular, or even blister-like, which is bullous PG. There's also a vegetative form that looks more warty.
Interesting.
And interestingly, it can sometimes be triggered by surgery, especially after certain procedures like breast surgery or a stoma creation. It can even be caused by some medications, or pop up around a stoma in people who have inflammatory bowel disease.
It sounds like diagnosing PG could be tricky then, especially if there isn't one single test that confirms it.
That's absolutely right. There's no specific blood test or, magic marker that definitively diagnoses PG. Doctors have to rely heavily on seeing that characteristic appearance of the ulcers, and this is crucial, ruling out all the other conditions that could possibly look similar. Infections, vasculitis, even cancer sometimes.
So it's a diagnosis of exclusion, partly?
Largely, yes. The text mentions something called the Paracelsus score, which is a tool doctors can use. It helps them weigh different clinical features to see how likely the diagnosis of PG is in a suspected case.
And it's also really important to check if patients with PG have any other underlying health problems going on, isn't it?
Absolutely essential.
Yeah.
In more than half of people with PG, it's linked to some other systemic disease. Inflammatory bowel disease like Crohn's disease or ulcerative colitis is a very well-known association.
Oh.
But it can also be linked to certain types of cancer, various forms of arthritis, and some blood disorders. Sometimes PG is even part of specific name syndromes that involve skin and other symptoms.
The source also brings up something called pathergy in relation to PG. What's that about?
Ah, pathergy. Yeah, that's a really fascinating and kind of strange phenomenon. It means that even minor injuries to the skin, like a needle prick, a biopsy stitch, even just a scrape, can actually cause new PG lesions to develop or make existing ones flare up and get worse.
Really? Just a small injury?
Yes, it happens in a significant number of PG patients, maybe 20–30% or so. So you can imagine this has big implications for wound care.
I bet. Like, you wouldn't want to aggressively debride the wound.
Exactly. Doctors have to be very cautious about aggressive debridement, cutting away dead tissue in PG wounds, because the trauma of the procedure itself could actually make the ulcer bigger or cause new ones. Gentle wound care might only be considered once the patient is on medications to calm down that overactive immune response.
And in terms of treatment, you mentioned medications. Is there a cure?
Unfortunately, there's no definitive cure for PG right now. The focus is really on getting the inflammation under control and promoting healing. Steroid medications are often a cornerstone of treatment.
How are they used?
They can be applied directly as creams or ointments for milder lesions, injected right into the edges of the ulcer, or given as pills for more severe or widespread cases. Though, of course, long-term use of steroid pills comes with its own set of potential side effects.
Right. What else works?
Medications that suppress the immune system are also really important. Cyclosporine is one that can be very effective, and the text specifically mentions infliximab. That's a type of biologic drug that targets a specific inflammatory protein called TNF-alpha. Studies have shown it can work well for PG.
Are there other options?
Yes, other topical treatments like tacrolimus cream or dapsone pills can also be helpful. And researchers are looking into other biologic medications, as well as a treatment called intravenous immunoglobulin, or IVIG, as potential options. But we probably need a bit more evidence on how well they work across the board.
Okay. Moving on within the inflammatory category, the chapter also discusses hidradenitis suppurativa, or HS. This is another chronic inflammatory condition, but it seems to affect different areas of the body than PG.
Yes, that's right. HS primarily affects the skin in areas where skin rubs together and where there are lots of specific sweat glands called apocrine glands, as well as hair follicles. So think under the arms, the groin area, around the buttocks and anus, under the breasts.
Then what causes it?
Again, the exact cause isn't perfectly understood, but it's thought to involve the hair follicles and possibly the sweat glands getting blocked and then becoming inflamed. This leads to the formation of these painful lumps or nodules deep in the skin, blackheads, and eventually these tunnels under the skin called sinus tracts that can drain pus.
That sounds really unpleasant and painful.
It absolutely can be. It often leads to significant scarring over time. HS tends to be a long-term chronic condition that can flare up and calm down, and it can really impact someone's quality of life because of the pain, the drainage, the scarring, and sometimes feelings of embarrassment or isolation.
And how is HS diagnosed? Is it also tricky, like PG?
Diagnosis is mainly clinical. It's based on seeing those characteristic lesions, the nodules, abscesses, sinus tracts, scars in those typical locations, and the fact that it's recurring. A skin biopsy can sometimes be helpful, maybe to rule out other conditions if the picture isn't totally clear, but usually it's diagnosed based on the patient's history and what the doctor sees on exam. They also use staging systems like the Hurley staging system to classify how severe the HS is.
And treatment, what's the goal?
The main goals are to reduce the number of new lesions popping up, treat the existing ones to reduce pain and inflammation, and try to prevent or minimize scarring and those sinus tracts from forming. It often involves a combination approach.
Like what?
Lifestyle changes can be important things like losing weight if needed, stopping smoking, as both seem to be linked to HS severity. Using special antiseptic washes can help reduce bacteria on the skin. Trying to avoid friction or irritation in those areas is key, and using absorbent dressings can help manage drainage.
And medication.
Yes, various medications are used, often targeting inflammation and bacteria. These can be topical creams or washes or pills like antibiotics, often used for their anti-inflammatory effects too. Retinoids, hormonal therapies in some women, and newer biologic drugs that target specific part to the immune system, similar to those used in PG or psoriasis. In more severe cases, surgery to remove the affected skin and sinus tracts might be necessary.
Let's switch gears now and talk about infectious causes of atypical wounds. The source notes that these can involve germs that aren't the usual culprits, especially maybe in certain parts of the world or in people with specific risk factors. Atypical mycobacterial infections are one example given.
That's right. So these are bacteria that are related to the ones that cause tuberculosis and leprosy, but they're different species. They're actually pretty common out in the environment, in soil, in water, both fresh and salt.
So they're everywhere.
Pretty much, yeah. But they weren't really recognized as causing significant infections in people until around the 1950s. Typically, these skin infections happen when the bacteria get into the skin through some kind of break a cut, a scrape, maybe even surgery or an injection.
Who gets them?
Often it's in people who've had some kind of trauma, or people with weakened immune systems, or those who have other chronic illnesses that make them more susceptible. The most common one causing skin infections from this group is called Mycobacterium marinum. You often get that from exposure to contaminated water, like in fish tanks or swimming pools, sometimes called fish tank granuloma.
Ah.
But there are many other species listed in the text, Table 22-8, that have been reported to cause skin problems.
And what do these infections look like?
They can actually look quite different, depending on the specific type of mycobacteria and the person's immune status. It can range from small, wart-like bumps or granulomas to superficial ulcers, maybe those sinus tracts draining fluid, or even large, open ulcerated lesions, often on exposed areas like hands, arms, or legs. The text actually shows a picture related to Hansen's disease, which is leprosy, caused by Mycobacterium leprae, just as an example of how a mycobacterial infection can manifest on the skin, figure 22-3.
So not one single appearance. How are they diagnosed then? Biopsy again?
Yes, diagnosis usually relies on getting a tissue sample. Then they try to grow the bacteria in the lab on special culture media. which can sometimes take a while. Or they might use more advanced tests like PCR that look for the bacteria's genetic material directly in the tissue.
And treatment.
Treatment really depends on figuring out exactly which species it is, because different atypical mycobacteria have different sensitivities to antibiotics. So getting that specific diagnosis is crucial. Treatment often involves a long course of multiple antibiotics, sometimes for months. In some cases, surgically removing the infected lesion might be part of the plan, maybe even combined with the antibiotics.
Okay. Another infectious cause mentioned is Buruli ulcer. This sounds like it's more of a problem in specific regions.
It is, yes. Buruli ulcer is a significant public health problem primarily in tropical and subtropical developing countries, especially in West and Central Africa, but also reported in Asia, the Americas, and Australia.
And what causes this one?
It's caused by another mycobacterium, Mycobacterium ulcerans, which is actually related to the ones causing TB and leprosy. It produces a toxin that destroys skin and soft tissue.
How does it present?
It typically starts as a painless bump or nodule, or maybe just an area swelling under the skin. But then over weeks or months, this breaks down and turns into a large, painless ulcer. A key feature is that the edges of the ulcer often look undermined or scooped out, and there can be significant swelling or edema around the ulcer.
Painless, you said. That seems unusual for a large ulcer.
It is, and it's one of the characteristic features, especially early on. As the disease progresses, it can destroy a lot of tissue, including fat and sometimes even muscle. If it's over a joint, it can lead to severe contractures, permanent stiffness, and loss of movement. In the worst cases, it can even require amputation. The text shows a picture of figure 22-4, illustrating the kind of extensive ulceration and skin damage that can happen.
That sounds devastating. Who's most at risk?
It mainly affects children between the ages of 5 and 15 in those endemic areas. While it's rarely fatal itself, the disabilities and disfigurement it causes can have huge lifelong consequences, affecting schooling, work, and social integration.
Is there effective treatment?
Fortunately, yes. Treatment with a combination of antibiotics, specifically rifampicin and streptomycin, or sometimes clarithromycin, usually for about 8 weeks, has been shown to be very effective, especially if started early. This antibiotic treatment can often heal the lesions and prevent the need for extensive surgery.
That's good news.
It is. However, many patients still need some form of surgery, like debridement to clean the wound or skin grafting to cover large defects. Healing can still be slow, and interestingly, the bacteria has ways of suppressing the local immune response, which might help it spread initially. So early recognition and starting those antibiotics promptly are really crucial to minimize the long-term damage and social impact.
Okay, the chapter also delves into deep fungal infections. That sounds like a broad category.
It is indeed. Deep fungal infections affecting the skin are generally divided into 2 main types based on how they start. You have subcutaneous mycosis, where the infection usually begins when fungal spores from the environment, like soil or plants, get implanted directly into the skin, usually through some kind of injury, like a thorn prick or a splinter. These tend to stay localized or spread slowly along lymphatic channels.
Okay, that's one type. What's the other?
The other main group is systemic mycosis that is spread to the skin. These infections usually start in the lungs when someone inhales fungal spores from the environment. From the lungs, the fungus can then travel through the bloodstream that's hematogenous, spread to other parts of the body, including the skin.
Are these common everywhere?
Not necessarily. Many of these systemic fungal infections are geographically limited. They're caused by fungi that live in specific regions, often in warmer climates. So a person's travel history or where they live can be a really important clue if a doctor suspects one of these. And as with many infections, having a weakened immune system can definitely increase the risk for both subcutaneous and systemic fungal infections manifesting in the skin.
The source then goes on to describe several specific types of these deep fungal infections. Sporotrichosis is one. What's that?
Yes, sporotrichosis. This one is caused by a fungus called Sporothrix schenckii. It lives in soil and on plants, famously on rose bushes and sphagnum moss.
Rose gardener's disease.
That's the nickname, exactly.
Yeah.
Infection usually happens when the fungus gets into the skin through a prick or a cut, often during gardening or handling contaminated plant material. It typically starts as a small, painless bump, maybe reddish, that slowly enlarges and might turn into an open sore or ulcer.
Does it spread?
Often, yes. The classic form is lymphocutaneous sporotrichosis, where the infection spreads along the lymphatic vessels draining that area. So you might see a primary ulcer, and then a chain of bumps or nodules appearing along the arm or leg, following the path to lymph channels.
How's it treated?
Treatment usually involves taking antifungal medications by mouth, like itraconazole, for several months. And interestingly, because this fungus doesn't grow well at higher temperatures, applying local heat to the affected area can sometimes be helpful as an adjunctive therapy.
Okay. Chromoblastomycosis is another one mentioned. Sounds complex.
This is a long-term, chronic fungal infection that affects the skin and the tissue just beneath it. It's caused by several different types of dark pigmented fungi that are typically found in soil and decaying vegetation, especially in tropical and subtropical climates.
How does it start?
Like sporotrichosis, it usually starts with the fungus entering the skin through minor trauma. The main sign is typically a very slow-growing, wart-like nodule or plaque, often on the extremities like the feet or legs. The surface can become scaly, crusted, or even ulcerated over time.
Is it hard to treat?
It can be quite difficult to treat effectively, yeah. It often requires long courses of antifungal medications, sometimes combining different ones. Other treatments like cryosurgery, freezing the lesions, or applying local heat might be used alongside the antifungals. And the text notes that in long-standing neglected cases, these lesions can sometimes undergo cancerous transformation, developing into squamous cell carcinoma. It can also lead to chronic swelling, lymphedema, and secondary bacterial infections.
Paracoccidioidomycosis, that one sounds very specific, maybe to South America.
Exactly. You got it from the name.
Right.
It's caused by the fungus Paracoccidioides brasiliensis, which is endemic, meaning it's regularly found, in the soil and vegetation of tropical and subtropical regions of Central and South America, particularly Brazil.
How do people get infected?
People usually get infected by breathing in the fungal spores, so the lungs are typically the primary site of infection. From there, it can spread through the bloodstream or lymphatics to other organs.
Including the skin?
Yes, skin involvement is common. It often causes painful mulberry-like ulcers, particularly in the mouth, around the nose, and on the face. Lymph nodes can also become enlarged. Diagnosis involves identifying the characteristic yeast cells, which often look like a mariner's wheel under the microscope, in samples from lesions or sputum. Treatment relies on long-term therapy with antifungal medications, like itraconazole or amphotericin B.
Okay, then there's mycetoma. The description sounds quite distinctive: swelling, sinus tracts, and grains.
Yes, mycetoma has a very characteristic triad of features. Localized, often massive, swelling of the affected body part, usually a foot or hand. The formation of multiple sinus tracts those tunnels under the skin that drain pus or oily fluid, and the presence of grains within that discharge.
Grains, like sand.
Not exactly sand. These grains are actually visible clumps or colonies of the microorganism that's causing the infection. And importantly, mycetoma can be caused either by certain types of fungi, that's called eumycetoma, or by specific types of bacteria called actinomycetes, that's actinomycetoma.
Ah, so it could be fungal or bacterial.
Correct. And telling the difference is crucial because the treatment is completely different. Antifungals for eumycetoma, antibiotics for actinomycetoma. It's more common in tropical and subtropical regions, often affecting people who work outdoors, like farmers or laborers, who are more likely to get minor puncture wounds on their feet or hands from contaminated soil or thorns. It usually starts as a slow-growing, painless nodule after an injury.
Is it treatable?
Treatment can be very challenging, especially for eumycetoma. It often involves a combination of surgically removing as much of the infected tissue as possible, which can sometimes mean amputation in advanced cases and very long-term, months to years, antifungal or antibiotic therapy. Relapses are common.
Cryptococcosis is another fungal infection mentioned, often linked to people with weakened immune systems, right, like HIV.
That's right. Cryptococcus neoformans and Cryptococcus gattii are the fungi responsible. Cryptococcal infection is probably best known for causing meningitis, which is an infection of the membranes around the brain and spinal cord, especially in people with advanced HIV/AIDS.
But it can affect the skin, too.
Yes, it definitely can. Skin manifestations can occur as part of a disseminated infection that started in the lungs, or sometimes as a primary skin infection from direct inoculation. Skin lesions are actually particularly common in organ transplant recipients who get cryptococcosis.
But what do the skin lesions look like?
They can vary quite a lot. They might appear as papules, small raised bumps, pustules, pus-filled bumps, nodules, ulcers, or even sometimes look like cellulitis or abscesses. Some lesions might resemble molluscum contagiosum. Diagnosing a primary skin infection involves culturing the fungus from a skin biopsy or lesion fluid and using special stains like India ink to see the encapsulated yeast cells. Treatment for primary skin cryptococcosis usually involves antifungal medications like fluconazole. Systemic infection requires more intensive antifungal therapy.
And finally, in this deep fungal category, there's phaeohyphomycosis. That sounds like a mouthful.
It is a bit. Phaeohyphomycosis isn't a single disease, but rather a general term for a group of fungal infections caused by various types of fungi that characteristically have dark pigment, melanin, in their cell walls, hence the pheo part, meaning dark.
Okay, who gets these?
These infections can occur in both people with weakened immune systems and those with apparently healthy immune systems. They often present as nodules, cysts, plaques, or sometimes ulcers on the skin, usually after the fungus gets implanted through trauma. The specific appearance and severity can vary depending on the fungus involved and the patient's immune status.
Are they becoming more common?
The source suggests their occurrence might be on the rise, possibly related to the increasing number of people living with compromised immune systems, like transplant recipients or those on immunosuppressive drugs. Diagnosis requires identifying the characteristic pigmented fungal elements in a tissue biopsy using stains and culturing the specific fungus. Treatment often involves surgically removing the lesion if possible, combined with antifungal medications, but some of these fungi can be resistant to standard antifungals.
Okay, let's move on from fungi to another specific bacterium, Vibrio vulnificus. This sounds like something people need to be aware of if they're near certain coastal waters.
Absolutely. Vibrio vulnificus is a bacterium that thrives in warm, salty, or brackish seawater. Think places like the Atlantic coast, the Gulf of Mexico. It's often concentrated in filter-feeding shellfish, especially raw oysters, during warmer months.
And how does it cause wounds?
There are two main ways. First, you can get a wound infection if seawater contaminated with the bacteria gets into a pre-existing break in the skin, maybe a cut you got while fishing, or shucking oysters, or just swimming with a scrape.
What happens then?
This can lead to rapidly developing skin problems at the site of the wound, including redness, swelling, pain, blistering, sometimes large blood-filled blisters called hemorrhagic bullae, and potentially progressing to a severe flesh-eating type of infection called necrotizing fasciitis, which we'll discuss more later. It can be very aggressive.
That sounds serious. What's the second way?
The second way is by eating contaminated raw or undercooked seafood, particularly oysters. This can lead to something called primary septicemia, meaning the bacteria gets directly into the bloodstream from the gut.
Who's most at risk for that?
This is particularly dangerous for people with underlying liver disease, like cirrhosis, or other conditions that cause high iron levels in the body, or weakened immune systems. In these individuals, it can cause sudden onset of fever, chills, dangerously low blood pressure, septic shock, and characteristic skin lesions, often those large blisters and necrotic ulcers, typically on the legs. Mortality is very high with primary septicemia.
So diagnosis involves?
For wound infections, diagnosis is usually made by culturing the bacteria from the wound or blisters. For septicemia, blood cultures are key. Treatment requires prompt administration of antibiotics like doxycycline plus cephalosporin, along with aggressive wound care for skin infections, which often includes surgical debridement. The key takeaway really is, be cautious with raw oysters, especially if you have liver disease, and be mindful of exposing open wounds to warm seawater.
And speaking of necrotizing fasciitis, the chapter also discusses it more broadly as an infectious cause, noting it can be caused by different types of bacteria, not just Vibrio.
Yes, exactly. Necrotizing fasciitis, sometimes sensationally called flesh-eating bacteria, is a rare but incredibly serious and rapidly progressive infection. It affects the deeper layers of skin, the fat underneath, and the fascia, which is the connective tissue surrounding muscles.
What makes it so dangerous?
It spreads incredibly quickly along those fascial planes, often much faster and wider than the surface skin changes would suggest. This rapid spread causes widespread tissue death due to toxins produced by the bacteria and cutoff of blood supply. It's a true surgical emergency.
Who gets it? Is it random?
Early recognition is vital, but can be difficult, because initially it might just look like cellulitis, a common skin infection causing redness, swelling, and warmth. However, a key distinguishing feature, emphasized in the text, is often severe pain that seems completely out of proportion to the visible skin findings. The patient might be in agony, but the skin just looks a bit red.
Pain out of proportion. That's the flag.
That's a huge red flag. Other early signs might include swelling that feels tense or hard, maybe some skin discoloration beyond simple redness, and sometimes crepitus, a crackling feeling under the skin caused by gas produced by some types of bacteria.
How is it categorized?
It's often categorized based on the types of bacteria involved. Type 1 is the most common and is polymicrobial, meaning it's caused by a mix of different aerobic and anaerobic bacteria. Type 2 is typically caused by group A Streptococcus alone, the same bacteria that causes strep throat, sometimes with Staph aureus involved. Type 3 is caused by gram-negative rods, including Vibrio vulnificus, usually related to marine exposure.
Where does it usually occur?
It most commonly affects the extremities, arms and legs, the perineum, the area between the genitals and anus. When it occurs here, it's specifically called Fournier's gangrene, which is particularly aggressive, or the abdominal wall, sometimes after surgery.
What happens if it's not caught early?
As it progresses, you start seeing more dramatic skin changes, maybe dusky or purplish discoloration, blistering, and eventually frank cutaneous gangrene, black dead skin. The tissues can start to separate easily. Beneath the skin, the fascia looks gray and necrotic, and there can be thrombosis, clotting of blood vessels, and even muscle death. Systemically, the patient typically develops high fever, chills, rapid heart rate, confusion, and can quickly go into septic shock and multi-organ failure.
How is the diagnosis confirmed?
While imaging like CT or MRI might show signs suggestive of NF, like gas in the tissues or fascial thickening, the definitive diagnosis often requires immediate surgical exploration. A surgeon needs to actually look at the fascia to see if it's necrotic. You can't afford to wait.
And treatment?
Treatment has two main pillars that must happen simultaneously and urgently. Aggressive surgical debridement, removing all the dead and infected tissue, which often requires multiple trips back to the operating room, and broad-spectrum intravenous antibiotics to cover all likely bacterial culprits. Supportive care for shock and organ failure is also critical. Mortality remains high, even with prompt treatment. The absolute key takeaway is suspect NF with severe pain out of proportion and get surgical consultation immediately. Don't wait.
Okay, moving away from infections now. The chapter then discusses vasculopathies as another category of atypical wounds. What's the common thread with these conditions?
Right. Vasculopathies, this is a diverse group of conditions, but the underlying theme is usually microvascular occlusion, meaning the tiny blood vessels in the skin get blocked, often by small blood clots, thrombi, or other material.
And this blockage causes problems.
Yes. This blockage cuts off or severely reduces the oxygen supply to the tissues fed by those small vessels. This leads to tissue injury or death, infarction, and can manifest on the skin in several ways. Common symptoms mentioned include purpura, those small bruise-like spots, often palpable, livedo reticularis, that net-like mottled pattern of blood vessels under the skin we talked about with vasculitis, and often painful ulcers that can be difficult to heal. Figure 22-6 in the text apparently shows some of these features.
So it's all about blocked tiny vessels. What are some specific conditions in this group? Cryofibrinogenemia is one mentioned. That sounds cold-related.
It does, and it is. Cryofibrinogenemia involves an abnormal protein complex in the blood, containing fibrinogen and related proteins that precipitates or clumps together when exposed to cold temperatures.
Where does this happen?
It typically happens in the small blood vessels of the cooler extremities, like the fingers, toes, ears, nose, and lower legs. This clumping blocks blood flow.
Can it happen on its own?
It can be primary, meaning it occurs on its own without a known underlying cause, or it can be secondary, associated with other conditions like infections, inflammatory diseases, or malignancies.
What are the skin signs?
The main clinical sign is often painful ulcers, typically on the legs and feet, that just don't respond well to standard wound care. Other skin findings can include that livedo reticularis pattern, purpura, acral cyanosis, bluish discoloration of fingers, toes, and sometimes even Raynaud's phenomenon or gangrene. Figure 22-7A and B are referenced as showing these painful ulcers.
How's it diagnosed and treated?
Diagnosis usually involves a skin biopsy showing the vessel occlusion without signs of vasculitis, inflammation of the vessel wall itself, and blood tests done carefully to detect the cryofibrinogen. The blood needs to be kept warm after drawing. Treatment focuses on avoiding cold exposure, stopping smoking, as smoking constricts blood vessels, and treating any underlying disease if it's secondary. Medications that help dissolve clots, fibrinolytic agents, or prevent clotting might sometimes be used.
Okay. Then there's cryoglobulinemia, another cold-related one.
Yes, similar name, similar trigger, cold, but slightly different mechanism. Cryoglobulinemia involves abnormal antibodies in the blood called cryoglobulins, which also precipitate or gel when cooled below body temperature.
How is it different from cryofibrinogenemia?
These cryoglobulins can deposit in the walls of small to medium-sized blood vessels, and this deposition can trigger inflammation, vasculitis, and/or form clots, thrombi, leading to vessel blockage and tissue damage.
Are there different types?
Yes, it's typically classified into 3 types based on the composition of the cryoglobulins. Type I is usually associated with blood cell cancers like multiple myeloma. Types 2 and 3, often called mixed cryoglobulinemia, are more commonly associated with chronic infections, particularly hepatitis C virus or autoimmune diseases like lupus or Sjogren's syndrome.
And the skin signs, similar.
Types 2 and 3, which often cause vasculitis, typically lead to skin manifestations like palpable purpura, very common, ulcers, especially on the lower legs, equinocyanosis, Raynaud's phenomenon, and livedo reticularis. Systemic symptoms affecting joints, kidneys, and nerves are also common with mixed cryoglobulinemia. Type 1 is more likely to cause symptoms just from hyperviscosity, thick blood, or vessel blockage without inflammation, like Raynaud's or ulcers.
Diagnosis and treatment.
Diagnosis involves skin biopsy, often showing vasculitis, and specific blood tests to detect and analyze the cryoglobulins, again requiring careful temperature handling of the sample. Treatment really targets the underlying cause. For example, antiviral therapy is crucial if it's linked to hepatitis C. For the vasculitis or severe symptoms, treatments like steroids or other immunosuppressants might be needed.
Next, vasculopathy. Cholesterol crystal embolism. This sounds like it's related to atherosclerosis, maybe.
Exactly. This condition occurs when tiny, needle-shaped cholesterol crystals break off from atherosclerotic plaques, which are usually located in larger arteries like the aorta or iliac arteries.
Where do they go?
These crystals travel downstream in the bloodstream until they get lodged in small arteries or arterioles, blocking blood flow. This blockage leads to ischemia, lack of oxygen, and infarction, tissue death, in the areas supplied by those vessels.
And it happens spontaneously.
It can happen spontaneously, especially in people with severe atherosclerosis, but it's often triggered by procedures that might disturb those plaques, like angiography, vascular surgery, or even starting anticoagulant or thrombolytic therapy.
What are the skin signs?
Skin manifestations are common and can include things like gangrene, often of the toes, sometimes called blue toe syndrome or purple toe syndrome, cyanosis, livedo reticularis, often very pronounced and widespread, purpura, nodules, and ulceration. It can be very painful. It can also affect other organs, especially the kidneys, causing kidney failure.
How is it diagnosed?
Skin biopsy is often key, as it can show the characteristic cholesterol clefts, empty spaces left by dissolved crystals within the blocked blood vessels. Finding these confirms the diagnosis.
And treatment.
Treatment is mainly supportive and focused on preventing further embolization. This usually involves managing risk factors for atherosclerosis, especially with cholesterol-lowering therapy like statins. Unfortunately, revascularization, like bypass surgery, is usually not an option because the blockage is in very small vessels. Interestingly, anticoagulation, blood thinners, is often avoided or used cautiously, as it might potentially increase the risk of more plaque rupture or bleeding into damaged areas. Wound care is important for any ulcers.
Okay, and the last vasculopathy mentioned in this section is antiphospholipid antibody syndrome, or APS.
Right. APS is an autoimmune disorder. The body produces antibodies directed against certain phospholipids, components of cell membranes, or proteins bound to them.
What do these antibodies do?
They increase the risk of developing blood clots, both in veins like DVT and arteries like stroke. APS is also associated with recurrent pregnancy losses and low platelet counts, thrombocytopenia.
Does it occur on its own?
It can be primary APS, occurring by itself, or secondary APS, occurring in association with other autoimmune diseases, most commonly systemic lupus erythematosus, SLE.
What are the skin signs associated with APS?
The most common skin finding, almost a hallmark, is livedo reticularis. But APS can cause a variety of other skin problems due to blood clots in small vessels. These can include ulcers, often painful on the legs or feet, superficial thrombophlebitis, inflammation of veins near the surface, cutaneous infarcts, areas of skin death, splinter hemorrhages under the nails, and sometimes a vasculitis-like picture.
How is it treated?
Treatment typically focuses on preventing blood clots, usually with long-term anticoagulation using medications like warfarin. Low-dose aspirin might also be used. For severe manifestations or during pregnancy, other treatments like heparin or sometimes steroids or immunosuppressants might be needed. However, the source notes that the response of skin ulcers and APS to treatment can be variable.
Okay. The chapter then shifts to metabolic disorders as a less common cause of chronic wounds, and it specifically highlights calciphylaxis. This sounds really serious.
It is extremely serious. Calciphylaxis is a rare but often devastating and life-threatening condition. It's characterized by progressive calcification, hardening due to calcium deposits, of small and medium-sized blood vessels, mainly in the skin and subcutaneous fat.
Who typically gets this?
It's most often seen in patients with end-stage renal disease, kidney failure, particularly those on dialysis, who often also have secondary hyperparathyroidism overactive parathyroid glands, and disturbances in calcium and phosphate metabolism. However, it could occasionally occur in people without kidney failure.
What does the calcification lead to?
This extensive calcification leads to narrowing and blockage of the blood vessels, causing severe ischemia, lack of blood flow and oxygen, and ultimately necrosis, death of the skin and underlying tissues.
What's the prognosis?
The prognosis is generally very poor with high mortality rates,
Mm.
often due to sepsis, overwhelming infection, originating from the necrotic skin wounds or from involvement of internal organs.
What does it look like initially?
It often starts with extremely painful, reddish or purplish, mottled patches on the skin that resemble livedo reticularis or purpura. These areas can become indurated, hardened.
On there.
These initial lesions typically progress rapidly to form hard, black, necrotic plaques called eschars. These eschars eventually slough off, leaving behind excruciatingly painful, deep, non-healing ulcers, often with irregular shapes. Small vesicles or bullae, blisters, might sometimes appear at the periphery of the ulcers. The lesions are often symmetrical and tend to occur in areas with more adipose tissue, like the abdomen, thighs, and buttocks, but can also affect distal extremities. Figure 22 to 8a and b, and figure 22 to 9 in the text or reference, showing these characteristic lesions.
It's also called calcific uremic arteriopathy, or CUA.
Yes, that term emphasizes the key pathology. Calcification of small arteries in patients with uremia, kidney failure, leading to thrombosis and tissue injury.
Why does this happen? Is it just high calcium levels?
The exact pathogenesis is complex and not fully understood. While high calcium and phosphate levels and elevated parathyroid hormone, PTH, are major risk factors, they aren't the whole story. It seems to involve an imbalance between factors that promote calcification and those that inhibit it. There's dysregulation of certain proteins that normally prevent calcium deposition in soft tissues, like fetuin A and matrix layer protein. Factors like warfarin use, obesity, diabetes, and female sex are also associated risks.
How is it diagnosed?
Diagnosis is often based on the characteristic clinical findings in a patient with risk factors, especially end-stage renal disease. Elevated serum calcium, phosphate, and PTH levels support the diagnosis. Imaging like X-rays might show vascular calcification. A skin biopsy is the gold standard, showing calcification of the vessel walls, intimal proliferation, thickening of the inner lining, and thrombosis, often without significant inflammation. However, biopsy itself carries a risk of non-healing or worsening the lesion.
How is it managed? It sounds incredibly difficult.
Management is very challenging and requires a multidisciplinary approach. Treating any infection in the ulcers is absolutely critical, as sepsis is a major cause of death. This involves aggressive wound care and antibiotics. Beyond that, efforts focus on correcting the underlying metabolic disturbances, controlling calcium, phosphate, and PTH levels, which might involve adjusting dialysis, using phosphate binders, cinacalcet, or even parathyroidectomy. Sodium thiosulfate infusion is an emerging treatment that seems to help some patients, possibly by acting as an antioxidant and calcium chelator. Pain control is also paramount. Table 2210 in the text likely summarizes these medical and surgical therapies. The key takeaway is, this is a dreadful complication, primarily seen in kidney failure patients, causing intense pain and skin necrosis due to vessel calcification.
Right. Next, the chapter addresses malignancies, cancers as a potential cause of wounds, or even something that wounds can develop into.
Yes, this is an important connection to be aware of, working in both directions. First, certain types of cancer that arise in the skin or underlying tissues can present as non-healing ulcers.
Which cancer?
Things like basal cell carcinoma, squamous cell carcinoma, the most common non-melanoma skin cancers, as well as less common ones like cutaneous lymphomas, sarcomas, or even metastatic cancer that is spread to the skin from elsewhere. As these tumors grow, they can outgrow their blood supply, leading to central necrosis and ulceration. Figure 2210 probably shows an example of this.
So a wound could actually be a sign of an underlying cancer. What's the other direction?
The other direction is when a chronic, long-standing wound itself undergoes malignant transformation and turns into cancer. This is most famously known as a Marjolins ulcer.
Marjolins ulcer. What type of cancer does it usually become?
Most commonly, it becomes squamous cell carcinoma, although other types like basal cell carcinoma or melanoma can occur rarely. This transformation is estimated to happen in a small percentage and maybe up to 2% of chronic wounds that have been present for many years, sometimes decades.
What kinds of chronic wounds are at risk?
It can happen in chronic venous ulcers, pressure injuries, old burn scars, especially third-degree burns, areas of chronic osteomyelitis, bone infection with draining sinus tracts, wounds from radiation dermatitis, or other long-term inflammatory conditions. Figure 2211 likely illustrates a Marjolins ulcer.
Why does this happen? Do we know?
The exact mechanism isn't fully understood. Theories suggest that the chronic inflammation, repeated cycles of tissue breakdown and repair, and perhaps exposure to toxins within the wound environment might damage DNA and promote cancerous changes in the regenerating epithelial cells. The weakened, unstable epithelium in a chronic wound or scar might also be more susceptible to external carcinogens.
So what's the clinical clue for this?
Any chronic wound or scar that suddenly changes in character, maybe it starts growing rapidly, develops raised or irregular borders, becomes more painful, bleeds easily, or just looks different, should raise suspicion for malignant transformation.
And biopsy is key again.
Absolutely crucial. A biopsy, perhaps multiple biopsies from different areas of the wound, is needed to confirm the diagnosis.
How is it treated if it is cancer?
Treatment usually requires surgical excision of the cancer. Because these can be aggressive, wide margins of healthy tissue around the tumor are typically removed. For certain types, like squamous cell carcinoma arising in chronic osteomyelitis, a specialized technique called Mohs micrographic surgery might be used to ensure complete removal while sparing healthy tissue. Depending on the type and stage of the cancer, adjuvant therapy like radiation or chemotherapy might be needed. In some advanced cases involving bone or extensive tissue, amputation might be necessary. The key takeaway is, always consider malignancy in a non-healing wound, especially one that changes, and be aware that chronic wounds themselves carry a small risk of becoming cancerous over time.
Okay, the chapter then covers external causes of atypical wounds. Here, getting a good history from the patient seems like it would be particularly important, right?
Absolutely. For this group of causes, the patient's story, what happened, what they were exposed to, is often the most critical piece of the diagnostic puzzle.
Spider bites are one example given. We often hear about brown recluse bites causing nasty wounds.
Yes. While most spider bites are minor, certain species can cause significant skin reactions. The Loxosceles genus, which includes the brown recluse spider found primarily in the central and southern United States, is the most well-known in the Americas for causing dermonocrosis, skin death, and ulceration. Figure 2212 likely shows such a bite.
Are the bites painful right away?
Often, the initial bite itself is painless or only mildly stinging, so the person might not even realize they've been bitten. But over the next few hours, pain, itching, redness, and swelling can develop at the site.
What causes the tissue damage?
The venom contains several enzymes, notably phosphoratase D and sphingomyelinase D, which damage cell membranes, trigger inflammation, activate neutrophils, and can cause blood vessel clotting, all leading to tissue destruction.
Is there a typical appearance?
A characteristic pattern can sometimes develop over 24-72 hours. The bite site might become bluish or purplish due to ischemia, surrounded by a ring of pale, blanched skin, which is then surrounded by a larger area of redness or erythema. This is sometimes called the red, white, and blue sign, or target lesion.
Does it always get really bad?
No. Most suspected brown recluse bites actually heal without significant problems within a few weeks. However, in a percentage of cases, the central area does become necrotic, forming a black eschar that eventually sloughs off, leaving an ulcer that can take weeks or even months to heal, sometimes requiring skin grafting.
Can it cause systemic problems?
Rarely, yes. A severe systemic reaction called viscerocutaneous loxoscelism can occur, usually within the first couple of days after the bite. This involves symptoms like fever, chills, nausea, muscle aches, and sometimes hemolytic anemia, red blood cell breakdown, kidney failure, and disseminated intravascular coagulation,
Yeah.
a serious clotting disorder. This is a medical emergency.
Does the location of the bite matter?
Yes. The text notes that bites in areas with more fatty tissue like the abdomen, thighs, or buttocks seem more prone to developing significant necrosis, possibly because the venom gets trapped there. Ulcer healing in these fatty areas tends to be particularly slow.
How is it treated? Anything specific?
Treatment is mainly supportive. Recommendations include cleaning the wound, applying cold compresses, intermittently, not continuous ice, which could worsen damage, keeping the affected limb elevated, and providing pain relief, analgesics, and tetanus prophylaxis. The use of specific treatments like dapsone or systemic steroids is controversial, with limited evidence supporting their routine use. Antibiotics are only needed if there's a secondary bacterial infection. Surgical debridement, removing dead tissue, is usually delayed until the area of necrosis is clearly defined, which might take a week or more.
Can it be mistaken for other things?
Absolutely. Many other conditions can be misdiagnosed as brown recluse bites, including bacterial infections like MRSA, viral infections like herpes, other insect or arthropod bites, vasculitis, pyoderma gangrenosum, and others. So definitive diagnosis based solely on appearance is difficult unless the spider was actually seen and identified. The key takeaway is that a painful, potentially necrotic lesion appearing after a possible bite in an endemic area should raise suspicion, but other causes need to be considered.
Chemical burns are another external cause discussed. Seems straightforward, but are there nuances?
Yes, a wide variety of chemical products used in industry, agriculture, the home, or even maliciously can cause skin wounds if they come into contact with the skin. The severity depends heavily on several factors.
Like what?
The specific chemical involved is key. For instance, alkali burns, caused by strong bases like lye or cement, are often more severe and penetrate deeper than acid burns because they cause liquefaction necrosis, allowing them to keep going deeper. Acids tend to cause coagulation necrosis, which can sometimes limit their penetration.
What else affects severity?
The concentration of the chemical, the duration of contact with the skin, the amount of chemical, and how quickly and effectively it's removed are all critical factors.
What's the most important first aid?
The most important initial treatment for almost all chemical burns is immediate and prolonged irrigation of the affected area with copious amounts of water for at least 20-30 minutes, sometimes longer, to dilute and wash away the chemical. It's important to remove any contaminated clothing first.
Are there exceptions?
There are a few specific chemicals that require special treatment considerations, in addition to, or sometimes instead of just water irrigation initially, though water is almost always the first step. Examples include hydrofluoric acid, which requires calcium gluconate application, elemental metals like sodium, which react with water, phenol, which might be better removed with polyethylene glycol initially, if available, and chromic acid. But for most situations, lots of water is key.
Okay. Radiation dermatitis is also mentioned as an external cause. This is from medical radiation mostly.
Yes, this refers to skin damage that occurs as a side effect of exposure to ionizing radiation, most commonly during radiation therapy for cancer treatment. It can also occur after accidental or occupational radiation exposure.
Does it happen right away?
The effects depend on the total dose of radiation received and how quickly it was delivered. Acute radiation dermatitis typically develops within days to weeks after exposure. Lower doses might cause transient redness, erythema, mild swelling, itching, and dry, peeling skin.
What about higher doses?
Higher doses, typically exceeding 10 grays, Curie as mentioned in the outline, can cause more severe acute reactions, including intense erythema, blistering, aciculation, sloughing of the skin surface, erosion or moist desquamation, and potentially ulceration. These wounds can be quite painful.
Are there long-term effects too?
Yes, chronic radiation dermatitis can develop months or years after the initial exposure. Long-term changes can include permanent alterations in skin pigment, lighter or darker, the appearance of small dilated blood vessels called telangiectasias, thinning and fragility of the skin, atrophy, hardness, fibrosis, and poor wound healing capacity in the irradiated area. Chronic radiation ulcers can sometimes develop long after treatment.
Is there any specific treatment for these ulcers?
Managing radiation-induced wounds can be challenging due to the underlying tissue damage and poor blood supply. Good wound care is essential. One treatment mentioned as potentially helpful for chronic radiation ulcers is hyperbaric oxygen therapy, HBOT, where the patient breathes pure oxygen in a pressurized chamber. This is thought to help by improving oxygen delivery to the damaged tissues and promoting new blood vessel growth.
And finally, under external causes, there's factitial dermatitis. This seems like a very different and sensitive category of wounds people inflict on themselves.
Yes, factitial dermatitis, or dermatitis artifacta, refers to skin injuries that are self-inflicted, either consciously or unconsciously, but where the patient typically denies causing them. Figure 2213 likely shows an example.
What might suggest a wound is factitial?
These wounds often have unusual shapes or appearances that don't fit with known disease patterns. They might have sharp, linear, or geometric borders, or bizarre configurations. They also tend to occur in locations that are easily accessible to the patient's hands, while areas like the middle of the back are usually spared. The patient's explanation for the wound might be vague, inconsistent, or improbable.
How is this managed? It must be complex.
Management is very challenging and requires a careful, non-confrontational approach. The primary goal is to protect the skin from further injury, often by using occlusive dressings or casts that limit the patient's access to the wound. Addressing any underlying psychological issues like stress, depression, anxiety, personality disorders, or a history of trauma is critical. This often involves psychiatric or psychological evaluation and treatment, which might include therapy and sometimes medications. Collaboration with psychodermatology specialists, if available, can be very helpful. The key takeaway is that wounds with bizarre patterns in accessible locations, coupled with a puzzling history, should raise suspicion for self-infliction, requiring sensitive management focused on both the skin and the underlying psychological factors.
The chapter also briefly touches on drug-induced causes of atypical wounds. Coumadin necrosis is one example. Coumadin is warfarin, the blood thinner, right?
That's correct. Warfarin, brand name Coumadin, is a widely used oral anticoagulant blood thinner. Coumadin-induced skin necrosis is a rare but serious complication of starting warfarin therapy.
How common is it?
It's estimated to occur in about 1 in 1,000 to 1 in 10,000 patients starting warfarin, so it's definitely uncommon.
When does it usually happen?
It typically occurs within the first few days, usually 3 to 10 days, after starting warfarin treatment. It seems to be more common when high initial loading doses are used, especially if warfarin is started without simultaneously using another anticoagulant like heparin as a bridge.
Why does it happen? What's the mechanism?
It's thought to be related to a temporary imbalance in the body's clotting system caused by warfarin. Warfarin inhibits vitamin K-dependent clotting factors, but it also inhibits natural anticoagulant proteins, specifically protein C and protein S. Protein C has a shorter half-life than most clotting factors, so its levels drop quickly after starting warfarin. This can lead to a transient hypercoagulable state paradoxically, an increased tendency to clot, particularly in the small blood vessels of the skin and subcutaneous fat, before the anticoagulant effect on the clotting factors fully kicks in. This leads to thrombosis, ischemia, and necrosis.
Are some people more at risk?
People with underlying deficiencies in protein C or protein S might be at higher risk. The source also notes that postpartum women seem to be at increased risk for reasons that aren't entirely clear.
What does it look like?
It typically begins as painful, reddish, or purplish patches of skin, like ecchymosis or bruising, often in areas with abundant fat tissue, like the breasts, abdomen, buttocks, or thighs. These lesions rapidly progress over hours to days, becoming more painful, developing blisters, often hemorrhagic, and eventually turning into well-demarcated areas of full-thickness skin necrosis with black Escher formation.
How is it treated?
The first step is to immediately stop the warfarin. If anticoagulation is still needed, heparin or another alternative anticoagulant should be used. Vitamin K might be given to help reverse warfarin's effect. Local wound care for the necrotic areas is essential, and this often requires surgical debridement and potentially skin grafting later on.
Can it happen again if someone restarts warfarin?
Yes, prior uncomplicated use of warfarin doesn't guarantee it won't happen in the future. However, the risk can be reduced by starting warfarin at a low dose, for example 5 milligrams or less per day, and ensuring adequate overlap with heparin for at least 4 to 5 days until the INR, a measure of blood clotting, is therapeutic.
Okay. And another drug-related cause mentioned is extravasation. What's that?
Extravasation refers to the accidental leakage of an intravenously administered fluid or medication out of the vein and into the surrounding soft tissues.
Can any 5E fluid cause problems if it leaks?
While simple saline leakage might just cause temporary swelling, certain types of 5E solutions and drugs are known as vesicants or irritants, meaning they can cause significant tissue damage if they extravasate.
What kinds of drugs are we talking about?
Examples mentioned include concentrated solutions like calcium chloride or potassium chloride, high-concentration dextrose solutions, certain vasopressors, drugs used to raise blood pressure, many chemotherapy agents, cytotoxic drugs, some antibiotics, and contrast media used for imaging. These substances can cause damage through various mechanisms, like direct toxicity to cells, causing intense inflammation, or constricting blood vessels. Figure 2214AC likely show the potential tissue damage.
What can the damage look like?
Depending on the substance and the amount leaked, extravasation injury can range from mild irritation and redness to severe pain, blistering, tissue necrosis, ulceration, and extensive tissue loss requiring surgical intervention. If it happens near a joint, like in the hand or wrist, it can lead to long-term problems with function, like stiffness or nerve damage.
How is it treated?
Treatment depends on the severity and the specific substance involved. Initial steps often involve stopping the infusion immediately, attempting to aspirate any residual drug from the IV line, elevating the limb, and applying either cold or warm compresses. The choice depends on the drug. Specific antidotes are available for some chemotherapy extravasations. Mild cases might resolve with local wound care. More severe cases with tissue necrosis require surgical debridement and possibly skin grafting or flap surgery to cover the defect. Scar management and physical therapy might be needed later, especially for injuries affecting function.
So prevention is really key here.
Absolutely. Prevention involves using careful 5E administration techniques. selecting an appropriate vein and catheter size, ensuring the IV's patent working well before starting infusion of a risky drug, diluting medications properly, infusing them at the recommended rate, and closely monitoring the IV site during infusion, especially for vesicants. Patients should be encouraged to report any pain, burning, or swelling at the IV site immediately. If extravasation is suspected, institutional protocols should be followed promptly. The text also makes a specific point about preferring calcium gluconate over calcium chloride for 5E calcium replacement when possible, as chloride is more irritating if it leaks. Thorough documentation of any extravasation event is also crucial.
Okay, before we wrap up, the chapter includes some really important teaching points for patients. It seems like details that might not seem obviously related to a wound can actually be critical clues for figuring out these unusual types.
Absolutely. Because the causes are so diverse, seemingly irrelevant details from a patient's history can suddenly become very relevant when considering an atypical wound.
So, what kind of things should patients make sure to tell their clinicians?
The text emphasizes informing clinicians about several things. For example, do you have inflammatory bowel disease like Crohn's or ulcerative colitis? That raises suspicion for pyoderma gangrenosum. Have you lived in or spent significant time in developing countries, especially tropical ones, that could point towards things like Buruli ulcer or certain deep fungal infections? Have you traveled to specific regions like tropical Central or South America, relevant for specific fungal infections like paracoccidioidomycosis? Do you eat raw oysters or participate in water activities in coastal areas like the Atlantic or Gulf Coast? Risk factor for Vibrio vulnificus. Do you have a history of chronic renal failure, or are you on hemodialysis? Major risk factor for calciphylaxis. Is your immune system impaired for any reason? e.g., HIV, transplant, immunosuppressive medication. Increases risk for various opportunistic infections like cryptococcosis or sporotrichosis. Are you taking certain medications like warfarin, Coumadin? Risk of necrosis.
It really highlights how a thorough history is more than just asking about the wound itself.
Exactly. These pieces of the puzzle, drawn from the patient's broader health, history, lifestyle, and travel, can be absolutely vital in guiding the diagnostic process for an atypical wound.
Okay, finally, the chapter summarizes the general approach to managing these challenging wounds. It sounds like, as we've discussed, the first step is often that tissue biopsy.
Yes, in many cases, tissue biopsy is the crucial first diagnostic step when an atypical wound is suspected. It helps identify or rule out specific causes like infection, inflammation, vasculitis, vasculopathy, or malignancy.
And once there's a diagnosis?
Once a diagnosis is made, the primary goal shifts to treating the underlying cause, if possible. That's paramount.
So, specific treatments for specific causes?
Right. That might mean appropriate anti-infective therapy, antibiotics, antifungals for infections, surgical removal for malignancy, anti-inflammatory or immunosuppressive medications for conditions like vasculitis or pyoderma gangrenosum, addressing metabolic issues in calciphylaxis, stopping an offending drug if it's drug-induced. Whatever the root cause, that needs to be tackled.
But basic wound care still matters too, right?
Absolutely. While treating the underlying cause is key, the fundamental principles of good wound care are still essential. This includes things like maintaining a moist wound healing environment, using compression therapy if appropriate, and if arterial insufficiency is ruled out, offloading pressure, ensuring adequate nutrition to support healing, and managing any pain or infection.
It sounds like healing can be a long road for these wounds.
Often, yes. Atypical wounds can frequently take a long time to heal, even with appropriate treatment of the underlying cause. Management might require multiple different treatment modalities used together or sequentially. This prolonged healing process unfortunately increases patient morbidity, suffering complications, and the overall cost of care.
Are there other therapies sometimes used?
Yes, various adjunctive therapies might be employed alongside the primary treatment to try and improve the effectiveness or speed of healing. This could include things like negative pressure wound therapy, hyperbaric oxygen therapy, advanced dressings, bioengineered skin substitutes, or other specialized treatments, depending on the specific situation.
It's really clear from all this that atypical wounds are a complex and incredibly diverse area. What might just look like a simple sore that won't heal could actually have a really fascinating and sometimes quite serious underlying cause.
Exactly. It underscores the importance of not just looking at the wound, but thinking critically about the whole patient, their history, their other conditions, how the wound is behaving. And the process of figuring out what's going on, that diagnostic journey, is so crucial. It often hinges on getting that thorough history we talked about, and frequently needing that all-important tissue biopsy to get definitive answers.
So thinking about all these different potential causes we've discussed, infections from soil or water, reactions to cold, metabolic issues, even spider bites, it makes you wonder, doesn't it? What everyday situations might unknowingly put us or people we know at risk for some of these less common wound types? And how can we as listeners maybe be more proactive about noticing unusual skin changes in ourselves or others and knowing when it's time to say, hey, maybe I should get this checked out? That's definitely something to ponder after our deep dive today.
It is. And if any of the specific conditions we've touched on, vasculitis, PG, Buruli ulcer, calciphylaxis, any of them have sparked your curiosity, we definitely encourage you to look into those areas further. Or, more importantly, if you or someone you know has an unusual wound or skin symptom that's worrying you, please discuss it with a healthcare professional.
Absolutely. Well, thanks for joining us for this exploration into the fascinating and sometimes puzzling world of atypical wounds.